All right, let's get right into it. We are going to build a visual map of some of the most critical medications in mental health care. And look, the goal here isn't just about memorizing facts for your next exam. It's about really truly understanding the why behind all the warnings so you can think on your feet when it really matters.
You know, what is the difference? A lot of the time, the answer is you and your clinical judgment. Knowing what's actually happening inside the body, the pathophysiology, is what separates a good nurse from a life-saving one. It's how you spot trouble before it turns into a total catastrophe, and that's exactly what we're going to visualize together today.
So, here's our game plan. We're going to walk through 5 major drug classes, and for each one, we're focusing on the highest stakes risk. We're talking serotonin syndrome, hypertensive crisis, lithium toxicity, NMS, and benzodiazepine withdrawal. Then, we'll wrap it all up with a safety checklist you absolutely can't forget.
First up, let's talk about the most common players in the game, antidepressants, and specifically SSRIs. I mean, they help millions of people, but they've got this dangerous shadow side that you have to be able to spot in a heartbeat. Okay, so what is this actually saying? Just picture the tiny gap between 2 brain cells. Serotonin is like a little messenger that jumps across that gap to deliver a signal. Now, after it delivers its message, there's this little vacuum cleaner, a reuptake pump, that sucks it back up. Well, SSRIs come in and basically put a block on that vacuum. This leaves more serotonin hanging out in the GAT, free to keep delivering those good mood messages. Pretty simple, right? But what happens when you have way too much of a good thing?
Well, that's when you get serotonin syndrome. And let's be clear, this is a full-blown medical emergency. The brain and the body are just completely overloaded. Think of it like a lightning storm inside the central nervous system. Everything is firing on all cylinders. You're going to see confusion, a heart that's racing, blood pressure shooting up, and a really high fever with tons of sweating. The muscles get super rigid and start to spasm. And the most critical thing to see here, the triggers. It's not just about mixing prescriptions like MAOIs. Something as simple as an over-the-counter cold medicine can be the thing that pushes a patient right over the edge.
Sticking with that idea of neurotransmitter overload, let's look at our next class, monoamine oxidase inhibitors. You know them as MAOIs. Now, these are older drugs, and they are incredibly effective, but man, they come with a massive risk. A literal ticking time bomb that's connected to what you eat, specifically an amino acid called tyramine.
And this image shows you exactly why. Okay, so look at the diagram on the left. In a normal body, you've got this enzyme called monoamine oxidase, MAO for short. Think of it as the cleanup crew. It breaks down extra neurotransmitters, like norepinephrine, inside your nerve endings. It also breaks down tyramine from your food. Now look at the right. The patient takes an MAOI, which inhibits that cleanup crew. So first you get this big buildup of norepinephrine inside the nerves. Then the patient eats something with tyramine. And because there's no cleanup crew in the gut, that tyramine gets absorbed, travels to those super-loaded nerve endings, and boom, it triggers a massive, uncontrolled flood of norepinephrine into the bloodstream.
And here's that domino effect, step by step. That flood of norepinephrine we just talked about, it causes massive vasoconstriction. I want you to literally picture every single blood vessel in the body squeezing shut at the same time. What happens? Blood pressure goes through the roof, leading to a hypertensive crisis. We're talking a blinding headache, a stiff neck, a heart pounding so hard you can feel it. It's a straight line from the dinner plate to a potential stroke.
So, what's our number one job here? Patient education. This is not a friendly suggestion. It's a life or death instruction. Patients on MAOIs have to avoid all of these foods. Just think of anything that's aged, cured, fermented, or pickled. We're talking aged cheeses, cured meats like salami, red wine, soy sauce, even avocados that have gotten too ripe. This list is a hard no.
All right, next up is lithium. It's the gold standard for treating bipolar disorder. But I want you to picture this. You're walking on a tiny, narrow ledge on the side of a cliff. On one side, you have the therapeutic dose that keeps your patient stable. On the other side is a sheer drop into life-threatening toxicity. And that ledge, it is incredibly narrow.
How narrow? This narrow. The safe, effective range for lithium in the blood is just 0.6 to 1.2, and the toxic level isn't much higher. A level of just 1.5 can mean you're already in serious trouble. There is practically zero room for error with this drug.
And you can see that progression right here. As that number starts to creep up, the body's systems start to shut down. Around 1.5, in that mild toxicity range, you'll see things like apathy and some coarse hand tremors. As it climbs up towards 2.0, it gets way worse. We're talking severe diarrhea, slurred speech, ringing in the ears. But once you get above 2.0, it is a code-level crisis. The body is literally being poisoned, which leads to seizures, coma, and yes, even death. You have to be able to connect these symptoms to that number.
So how do we keep our patients safe on that narrow ledge? This right here is the single most important intervention. See, the kidneys are what clear lithium from the body. But they have this one little problem. They can't tell the difference between lithium and sodium. So if a patient gets dehydrated or they suddenly cut back on salt, their kidneys freak out and start trying to hold on to sodium. But in the process, they accidentally hold on to lithium too, and that blood level starts climbing into the danger zone. That's why consistent fluid and salt intake isn't just a good idea, it's absolutely mandatory.
Okay, let's switch gears and talk about antipsychotics. Their main gig is to manage symptoms of psychosis, things like hallucinations and delusions. And they do this mostly by blocking dopamine receptors in the brain. But, well, when you start messing with dopamine, which is the key neurotransmitter for movement, you create a whole new set of problems.
Now, antipsychotics basically come in two main flavors. You've got your first generation or typical antipsychotics. These are great at treating the positive symptoms, the things that are added by the illness, like hearing voices. Then you have the newer atypical antipsychotics. They're generally better for the negative symptoms, the things the illness takes away, like motivation, emotional expression, or the ability to speak.
And because these drugs block dopamine, they can cause this whole cluster of side effects that look a lot like Parkinson's disease. We call them extrapyramidal symptoms, or EPS. The big ones you need to remember are akathisia, which is this horrible feeling of inner restlessness, like you can't sit still. Dystonia, which is painful muscle spasms, a lot of times in the neck and face. And then Parkinsonism itself, with that classic tremor and rigidity.
But just like with the other drug classes, there is a rare but incredibly deadly crisis you have to be watching for: neuroleptic malignant syndrome, or NMS. This is a true medical emergency, and it can happen at any point during treatment.
And this is what NMS looks like. The classic hallmark sign is extreme muscle rigidity. We call it lead pipe rigidity. This comes along with a super high fever, what we call autonomic instability, so the heart rate and blood pressure are just all over the place, and a change in their level of consciousness. You can basically think of it as the body's thermostat and muscle control systems completely short-circuiting at the exact same time. It needs immediate aggressive intervention.
All right, on to our last class, the anxiolytics or anti-anxiety meds. We're going to focus on the big guns here, the benzodiazepines. Their whole job is to put the brakes on the central nervous system.
So how do they actually do that? Well, they boost the effect of a neurotransmitter called GABA. GABA is the body's main inhibitory or calm down signal. So if you think of your brain's excitatory signals as the gas pedal, GABA is the brake. Benzodiazepines just come in and make that brake pedal way, way more powerful, which is what leads to that feeling of relaxation.
But here's the catch. The body gets used to having that super-powered brake pedal. If you suddenly take the benzodiazepine away, it's like you've slammed the gas pedal to the floor with no brakes at all. The central nervous system just goes into absolute overdrive. This causes some really severe withdrawal symptoms. And the most dangerous of all are seizures. And yes, those seizures can be fatal. That is why a patient can never just stop taking a benzodiazepine cold turkey.
Phew, we have covered a ton of ground and a lot of really serious danger zones. So let's just boil this all down to one final priority safety checklist that really applies to all of these drugs. This is the stuff every single patient has to know. Number 1, as we just saw with benzos, and it's true for so many others, you never ever stop the medication abruptly. It always has to be tapered down under medical supervision. Number 2, a lot of these drugs can cause dizziness and falls, so patients have to learn to change positions slowly. And number 3, and this is a big one, absolutely no alcohol. You cannot mix alcohol with drugs that are already depressing the central nervous system. It's a recipe for disaster that could lead to respiratory arrest and death.
So, let's end on this thought. We've literally traced the path from a single pill to a neurotransmitter all the way to a life-threatening crisis. We've visualized the why behind every single warning, so now the question for you is, which of these connections, which of these critical nursing interventions is now permanently burned into your clinical brain? Because that right there, that's the knowledge that saves lives.